I'm Tara Whitaker. I am a family doctor at Capital City Family Medicine. I also do some medical oversight at some of the local psych hospitals. So working with the medical teams there if there are kind of internal medicine or actual like non-psychiatric issues that people are dealing with in that setting as well. And our talk today, I was interested in this topic. I mean, I think something that comes up a lot, and in my practice, so my practice is general family medicine, and menopause and perimenopause, questions about that, and specifically a lot of requests recently, I think, because a lot of different services are being offered both in the community and online regarding hormone testing and how our hormones dictate all these things that can happen. And that is absolutely true. But what we don't know yet is exactly how to individually target some of the treatments we have. So what I'd like to do today is go through and specifically in the lens through the mental health lens, talk about how hormones affect behavioral health and give you some evidence-based suggestions. So yeah, next slide. So basically, learning objectives, let's introduce some mental health implications of the perimenopausal and menopausal phases of life. I'm going to focus mostly on depression, partly because that's what's been studied the most, even though the data is not perfect. And then I'm going to introduce some principles of best practice and evidence for treatment of these conditions and discuss indications for both hormone testing, like with lab tests, and hormonal interventions based on current evidence. Next slide. So looking at menopause, like demographics, just to define it. And what's really interesting when you kind of dig into the research on this is that part of the problem with some of the research is that the definition actually, depending on who did the study, the definitions are a little bit loose, especially with perimenopause. But just menopause, when we say menopause, menopause is a natural event. Postmenopause is defined by the final menstrual period and confirmed after 1 year of no menstrual bleeding. So again, usually, the natural course of that is that people naturally just stop menstruating at a certain point, and after a year, we can say they are postmenopausal. And this represents a permanent cessation of menses resulting from a loss of ovarian follicular function, meaning we're not ovulating anymore. And this is usually because of aging, but you can have surgical menopause where you remove the ovaries. And then the median age that this happens, they have 52.54. So average age that period stops, not 1 year after, but the period stops is about 52 and a half. And then, noted, many women will spend a huge portion of their life post-menopause. So I think all of that's just really to define what we're talking about. Perimenopause can start well before that. I think and I didn't put it in here, but it could be really, we talk about being in the 40s, and there isn't a great perfect definition of this, but really what we're talking about is this slow change in the hormonal status, which can be accompanied by a wide range of physical symptoms that starts happening leading up to menopause, but really can start even up to 10 years before someone is going to go through that actual menopausal transition. But for most people, that's relatively subtle. However, those symptoms can get pretty significant, including a lot of the things we associate as menopausal symptoms, like hot flashes, can get really significant well before people actually stop bleeding. So next slide. And then I made some allusions to this, but I was actually really interested to see, especially when it came to some of the mental health stuff that I'm going to talk about, that our evidence base is not super robust. So I think about this a lot when I do gender affirming care, and I talk to patients like, hey, there's a lot we're still learning. The evidence we're drawing from is not perfect, and this is where we're at. But it was really interesting to see that the quality of evidence for specific treatments, especially in regards to mental health, I should say, for perimenopausal and menopausal women, is not super definitive, I would say. So studies are small. studies seem to be pretty short. There are those inconsistent definitions of perimenopause and then some really inconsistent design. So again, some of that's a little better when we're talking about other types of symptoms like hot flashes. I would say the quality overall a little bit better, but again, focusing on specifically how do we treat mental health in this context, I would say I was not impressed by the quality. I'm going to present what we have right now, but this presents a problem and also potentially an opportunity, which is we really have to focus on the patient in front of us and know that what we're offering are guidelines. We want to keep people safe, but we also want to acknowledge that our goal is to treat the patient in front of us and really use the tools we have with the best evidence we have at any given time to get our patients feeling as best they can. So next slide. So I'm going to start with a case that actually came into my office a couple months ago. I think Dr. Weathers might have actually taken care of this patient, but I think this is an illustration of something that happened that really should not have happened. And the patient said it was fine to present this, but the case is a 46-year-old female who presented to her OBGYN for evaluation of irregular menses. She did not have significant hot flashes. She was complaining, though, of insomnia, anhedonia, just not enjoying things, some anxiety, and then worsening pretty significant depressive thoughts. And these had been becoming more severe with suicidal ideation. Her PHQ, they did a PHQ in the office. It was 20, and she did mark that question about suicidal ideation as positive. So the provider, and again, you're going to a specialist who's focusing more on the physical piece, ordered hormone testing, and the patient left the office. Doesn't look like they got a safety plan. Again, hard to know what happened in the office. She was given a preliminary diagnosis of PCOS, though they didn't even have the testing back yet. And with possible contribution from perimenopausal hormonal changes, but was sent home to wait lab results. And then, unfortunately, she presented 36 hours later after a suicide attempt by overdose with acetaminophen and was admitted to the hospital. She was medically stabilized and admitted to psych, discharged on sertraline with counseling, and she's actually done really, really well. Periods were subsequently addressed through, believe, a hormonal IUD, but again, hormonal symptoms pretty well controlled still at this point, and we'll talk a little bit more about how the sertraline may have helped with that. So I think if you take one thing home from this, it's that if someone is depressed, especially with suicidal ideation, that should be the focus. Sorry, the next slide was the second part of that case. Sorry, Shannon. And then, so yeah, that's what happened. And then the next slide, you can go to the next one. So yeah, I think that's a take home for sure. So looking at menopause and depression, basically a pretty common symptom in the perimenopausal and menopausal period, but from everything we've looked at, it looks like that's absolutely multifactorial. So most predictive factor for depression at midlife and beyond is prior history of clinical depression. If you have a woman who was depressed in her 20s and then is going through menopause, might be slightly higher risk. And we're doing in primary care in my office, we do PHQs on like a screening on everyone who comes in. And I think it's a great time to be checking in with patients again about their mood. Other predictive factors are history of PMS or PMDD, history of postpartum depression. The fact that you're having this menopause transition can be a predictor for depression itself, and then history of abuse or trauma. And then perimenopausally, depression symptoms are noted in a super high amount of perimenopausal women, so 45 to 70%, whereas premenopausally, like before that kind of start of the transition, it's only 25 to 30. And then they did a specific study that broke down by race and ethnicity, and it looks like Hispanic women were more vulnerable, but again, didn't define exactly why. So I think when reading through a lot of this stuff, it talks about how this is not necessarily a hormonally dictated problem, but that there's a lot of other things going on at midlife that can cause stress, there's a lot of transition, and that also comes at this time of hormonal shifting. You can go to the next slide. So again, looking at the data, there's not this perfect link between the mechanism of connecting the menopausal time frame to the symptom of depression, and also there isn't the perfect ideal treatment. Just a note about that standardization, but then also this idea that it's expressed and experienced differently depending on a lot of factors. So again, going back to our goal of treating the patient in front of us, physical health will dictate both menopausal symptoms as well as mood. This is a time when a lot of women start for the first time having a lot of cardiovascular issues, if that's been something that's been building up. So start getting, new metabolic risk, starting new medications. Cardiovascular events are very predictive of depression as well. So again, menopause or no, this is a time where some people start to have those events pretty early, but it does happen. And then the presence and severity of vasomotor symptoms does seem to correlate with some depression. Sleep changes are prominent, and we'll talk a little bit more about that. Some predictors based on ethnicity, and then lifestyle behaviors definitely tend to dovetail. So if people are drinking more around that time, smoking, exercising or not, definitely can predict some symptoms. And then stressful life events. So you think midlife, aging parents, kids going to college, or still in the house raising kids, relationship stuff, like a lot that dovetails right at that moment that can lead to higher stress states for women in this age group. We can go to the next ones. And then we think about, like, is there an actual estrogen connection? So menopause, estrogen dips, kind of drops down pretty significantly. And that's one of the, when you look, there's a real shift in how the body is flooded with estrogen. And there is a plausible physiological connection to mood regulation, but again, really lacking in, this is much more of a, theoretical connection rather than something we've studied. We know this is how the brain reacts in everybody. So there are estrogen receptors in the brain, including areas that are involved in mood regulation and cognition. And estrogen does appear to be a modulator of serotonin and noradrenaline. But again, it's probably a much more complex interplay than less estrogen makes you depressed. But again, it's definitely a plausible connection that estrogen could impact mood pretty significantly, as we see in so many ways when that system is dysregulated. So again, if you've identified depression in women in midlife, or people going through menopause, I should say, thinking through first line treatment, so specific management strategies. Again, we don't know for sure, but SNRIs and SSRIs seem to have the most evidence. There have been some studies. It's definitely a very those absolutely appear to be first line. There's no evidence that the studies that have been done, those short, are very supportive of that treatment. Not to mention, again, if we just look at the depression, these are our first line anyway, so really good place to start. They also seem to improve hot flashes, night sweats, and somatic complaints in a lot of women. So again, oh wait, sorry, I'm on the next slide, Shannon. So they did improve hot flashes, night sweats, and somatic complaints in a lot of women. And so again, there might be a win-win there depending on which is primary. And then there are some studies that show that an SNRI alone appears better than an SSRI alone. But then if you add estrogen to that mix, in that study, or in the studies that they looked at, it looked like that closed the gap, which was interesting. Next slide. And then the other treatment strategy that I kind of reviewed some of the evidence on is that estrogen therapy, both alone and in combination, does really show promise. So there's mounting evidence for this independent antidepressant effect, but it's a little bit confusing because it was very dependent on the population you studied. So new onset or recurrent depression and perimenopause, there were some small randomized controlled trials that were well designed. It was just not a lot of patients, but it really showed that the estrogen therapy was helpful for mood. And that effect did seem to be independent of hot flashes. So it wasn't just that we were treating the hot flashes and that made people happier. It was independent of whether or not they even had hot flashes at baseline. And then it also showed promise as an augmentation. So you have someone on SRI, they're doing okay, but adding estrogen seemed to augment it the same way we use other augmentation strategies for antidepressants. And then really things were either supportive or neutral. When we looked at all the studies, it was, kind of thinking through, they were small studies, but when you take them as a whole, the studies were generally supportive. The least kind of encouraging studies for estrogen use were really neutral. It didn't look like there were a lot of studies that showed that estrogen was harmful or caused depression in perimenopause and menopause. But it definitely looked like there were some that showed it was an effect similar on par with an SSRI or SNRI. And it did look like the critical window, or that there might be a critical window, because it really looked like there was a more robust response in perimenopause and early menopause rather than in people who were, postmenopausal. So 5 to 10 years out from menopause, adding estrogen back in. And again, most guidelines really are not super supportive of starting estrogen much later in postmenopausal women. So it did look like the estrogen effect was most robust when it was started more in that transition period. And then there is this really significant placebo effect. So this was a really interesting study where they tried to study estrogen effects, and they used a sham patch of estrogen, because estrogen a lot of time is delivered in a patch, and they used an estrogen patch, and the placebo group did great, as did the estrogen group. So both did better than nothing. And so it was an interesting question of, again, there's a lot of research that's hard to interpret when the placebo is really strong. So another example, people who get knee injections, placebo injections where they don't inject any medicine actually can a lot of times help people feel better with arthritis. So you have to overcome a pretty strong placebo effect to prove efficacy. But I just think that's another interesting thing to keep in mind. And then very small studies, but there is a possible role in prevention. So again, when you give estrogen to women who don't have depression, there was a study that followed them. I think it was about 170 patients, and they followed them out prospectively. So basically, they just started everyone on estrogen, and then they watched to see who got depression. And the group on estrogen actually did have lower rates of depression than the control. So again, not definitive, but it does look like there's a possible role for estrogen in prevention of depression in some women. So next slide. So again, this is pretty broad strokes, but I think the way I'm thinking about it right now is that if you have severe depression and minimal hot flashes, vasomotor symptoms, and again, anytime there's severe depression with suicidal ideation, we have to go down that path. We have to keep patients safe. So targeting depression first with our more robust bedrock of antidepressant treatment, depression treatment, is really where to start. And then you could consider hormonal intervention as augmentation, or if there's more hot flashes that come on, that's still absolutely at our disposal. Minimal to no depression, especially with significant hot flashes, then probably targeting that first with hormonal or non-hormonal options would be a good place to start. And then you could consider depression treatment as secondary. Again, some of the non-hormonal options when you just are trying to treat hot flashes are actually antidepressants. So I think that's another way to really to play with that. Again, you can always start with the hormones or the non-hormonal options, depending on the patient in front of you. But this is pretty logical, and I think helps keep us a little bit out of trouble. That's about, I have a few more, I have a couple more cases and a few more slides, but are there questions? What questions do people have?
Yeah, Tara, I had a question for you. Do you find that your patients come in with like some preconceived ideas of, oh, I think I need an antidepressant, or oh, I think I need hormone replacement? Like, what are you seeing, or what do you experience? And also, I'd be interested in what some of the other practitioners are seeing or experiencing.
Yeah, does anyone else have thoughts about that? Or even, I get questions from counselors or from, more mental, like behavioral health providers about like what hormones what should we test? And again, I have another talk that I'm going to give a little bit more about like general medical considerations, but is anyone getting more questions about that, or how do they approach it?
I see a lot of women who are kind of in this space, but I think one of the preconceived notions that so I'm Rachel Rood, I'm a psychologist. One of the things that I see more often in terms of preconceived notions is, I think a lot of times a preconceived notion that if they take these concerns to their medical provider, that they're going to get blown off. If I'm being totally honest, I get that a lot from patients, or not knowing how to talk about it, or to say, just that fear of bringing something to the table and being kind of dismissed. And so, I talk with a lot of people through that, and obviously would love some tips from any of the medical providers that would say, hey, this is a good way to talk about it, or this is a good way to encourage patients to bring those things in. And there is sometimes, my patients will go in and will get kind of dismissed. So I don't know. That's a preconceived notion that I see a lot.
Yeah. No, and so I think that's such a good point. Like the last thing we want anyone to feel is that we can't talk about these things. And that goes for mental health, that goes for hormone changes. I get a lot of patients who are like get embarrassed. They like saw something online and they're like, I looked online. And I'm like, of course you did. We all look online. We look online all the time. Tell me what you saw. Like, I want to help. And, sometimes patients will come to me and say, yeah, I found this thing online, and we look at it together. And, I'm always open to learning from the new things that are developing. I think one of the points why I keep making this point about the data is that we're learning, like we're painfully learning as we go. And so I think to really, like, for me, what works is to really listen to what the patient is struggling with, and then try to figure out why. Is there a why we can find? What are the tools at our disposal, to help them and guide that process. So I think, no one, no matter how out there the request, should feel like bad for bringing it. I think my goal is always to try to, if it's a request I don't think is totally appropriate medically, try to figure out how to explain that in a way that they understand and support. And I think it's actually the next, let me see if this is the one. So this is actually, the next couple cases, which again, I think we're running low on time.
You want me to pull them back up, Tara?
Well, how much time do I have?
You've got like 5 minutes.
Okay, let me just tell you those two cases, because I think it actually it elucidates one of these questions. So what I was going to say is one of the things, and again, so somebody will come in, and this is actually, will you go to the case 3 actually? So, so I get the request, and I really, I'm going to be full disclosure. It can be a frustrating request because it doesn't make sense. So what the request is someone will come in and be like, I want all my hormones tested. That's the ask. And the fact is, there are so many hormones in the body. They are tiny molecules that are all throughout our body. They're generated in all these different ways. They are very powerful. We are learning about them all the time, like the developments in the obesity space with hormonal triggers for obesity, the developments in, even, menopausal and sex hormone space, the fertility space. Like, we're learning all the time, and there's all these different hormones we can test. but I totally get the question. And so I think my goal is always to say, why are we getting a test? What is it going to do for us? So this case is 43-year-old female, increase in irritability, poor sleep, weight gain, and increasing menstrual irregularity. She asked about perimenopause and hormone testing. She's not really having hot flashes or like traditional vasomotor symptoms. PHQ 11, so maybe mild depression, but she has significant work and home stress and is really not, a lot of that PHQ content seems more stress related. So in this case, I did go ahead and draw labs. So I did, glucose, cholesterol panel, those are kind of standard, because her weight was a little higher. And then I did a thyroid test, which is a hormone test. Thyroid can lead to irregular menses. It can lead to actually hot or cold feelings, a lot of different symptoms. All that was normal. But in this case, I did not test her estradiol, progesterone. LH and FSH are hormones that come from the pituitary that tell your estrogen what to do, or testosterone at that time. So if you go to the next slide. So what I explained, sorry, a little typo there, but that the utility of testing for sex hormones, basically testing to see whether you're in perimenopause in a menstruating woman, is pretty minimal based on current evidence. So swings in hormones, if you're still menstruating, are very difficult to interpret. You can tank out on your estrogen just based on where you're at in your menstrual cycle. You can get low on your progesterone. And if you're still technically menstruating, it sounds like you're having a period, even if it's a little irregular, really says you're not truly menopausal yet. But again, that doesn't negate that you're having all these symptoms. So I'm like, yes, I absolutely believe you're having all these symptoms. It absolutely could be perimenopause. It is looking that way, but no lab test I could order would actually give us an answer. I can give you that answer without the lab test. Is kind of my spiel. But again, I think you really want to listen to the symptoms they're having and acknowledge that there could be this hormonal component. It's just hard to test for. So treatment is great. It's very patient-centered. Sleep behavior training, cognitive behavioral therapy for insomnia. You could consider hormonal intervention to either help regulate menses if bothersome, but you wouldn't necessarily guide that by labs. You choose based on her profile. Counseling, stress reduction, consider an SSRI. So again, hormone testing in that case, not super duper helpful. But if we go back to case 2, so this was a 51-year-old who had had a uterine ablation at 46 for heavy periods. And she came in complaining of hot flashes, night sweats, and these were interfering with work and sleep. Her PHQ was also 11 for some mild depression, fatigue, which she really felt like was more related to how little she was sleeping and how bad she felt a lot. No previous history of depression. She's also having some vaginal dryness, which is a classic low estrogen symptom. No unintentional weight loss with the night sweats. Her cancer screenings are all good. So I drew her labs. I did some wellness labs. And then for her, I actually did see a utility in measuring at least a couple of her hormone labs. So again, FSH and estradiol, and maybe LH and progesterone. And if you go to the next slide, basically the only way to confirm menopausal status technically in a woman with a uterine ablation is to draw labs. If in this case, you could even debate that you absolutely need it, but the goal really for me in this case was to prove that we knew why she was having hot flashes. There's actually some other medical causes for hot flashes. So I wanted to be sure we weren't missing, because if her hormones looked well above the menopausal range, then I need to keep looking for why she's feeling bad. But no other new underlying medical conditions were identified. She had classic findings of menopause, and we talked about hormonal and non-hormonal options, and she decided to go with hormonal therapy. So estrogen patch and oral progesterone is generally where I start. And we also talked about support for the vaginal symptoms, including vaginal estrogen, behavioral strategies for sleep, and it made the world of difference. So her PHQ was fully resolved at follow-up. And we titrated and we got her symptoms under control. And she was doing really well that way. So I think it really does come down to treating the scenario, and hormone testing absolutely can be, even, for those hormones, can be really, really helpful in some patients based on our current evidence. Any other questions?
Dr. Crownover, I saw you took yourself off of mute earlier. I wanted to make sure we got to you if you had a question.
Oh,
I was just going to get in a little bit as she got into on those last cases in terms of preempting the ladies in their 40s, asking about systemic symptoms versus local symptoms, and systemic symptoms get systemic therapy and local symptoms get local therapy, and just asking them, are you having pain with sex? That can lead to depression and marital conflict, and being very quick to putting in the vaginal estrogen, whether it's the tabs, the cream, the ring, or the systemic therapies. If you're having systemic symptoms, let's use systemic therapies. But I like your point about the FSH and the hormones, because so many women will come in here from going to these MP natural clinics, and they'll have profiles with hundreds of dollars of hormone testing. And I'm not going to treat a lab slip. I'm going to treat a person. So if you're having symptoms, then I'll treat the symptoms. And I don't care about balancing your lab slip. I want to balance you. If you got a uterus, I'm protected with progesterone. If you don't have a uterus, I don't want progesterone, because it's going to bump up your breast cancer risk. But they come in the door and they're all, gangbusters. And I got to take progesterone because my lab slip is low. You don't have a uterus. You're going to get breast cancer. Stop it. So, I mean, all these things come into play, whether it's fatigue and then there's sleep apnea, and their depression. So trying to mix all this together, menopause and mood, there's so much that comes in. Question I had for you though, Tara, was what do you like other than Dottie when they don't want to take Dottie, because they say that the glue makes things bad, but I tell them, you don't want estradiol pills, even though they're cheap, because they're gonna bump up your sex hormone binding globulins and drop your testosterone libido. Plus they bump up your clot risk. So I want topical.
totally. No, it's a good question. I think off the top of my head, I'll actually get back to you, because I actually off the top of my head don't have in terms of the adhesives. I'm trying to think of the last patient. Let me look at what we ended up doing, because I'm trying to remember what I did, because I've had that issue with the adhesives, and I'm totally with you. It's such a good point with the where we're at. The oral does tend to be seen as higher risk than topical, like a patch. Definitely. And then
because they can go compound, but then that's more money. So they don't want that.
And exactly.
And then they've got some spray-on gels and things that you can use, but those are pretty pricey.
Exactly. No, and I think that is what's tricky, is some insurances will cover it, but even some insurances, it's hard to get a lot of the the vaginal creams covered, or the tabs. I've run into that for sure.
Well, the rings especially.
Yeah, absolutely. So hard. And so, yeah, I think, let me look and see what we did. I thought that there were certain, like, depending on the patch, the adhesive might have been different, but let me see what I came up with. I'll get back to you. But what's such a good point around, treating the patient in front of you. I also want to, point out that part of the difficulty, and again, Rachel, kind of getting back to your patients feeling dismissed, I think there are providers in our community around the country, online, who are testing hormones a lot more aggressively than what I just presented. We may get to a point where we have evidence to support that. I don't know, because again, we don't know yet. So what I try to do, especially if someone's really committed or has heard from their hormone provider that they're going to titrate to the hormones, which sounds really good, then I really try to be gentle about, like, hey, we may not need to spend this money. Like, how are you actually feeling? Let's treat you. And I think patients generally respond to that. I think if they really trust their other provider, if I come out being like, oh, this is crazy, then it runs the risk of making them feel bad about it, I think, which is not the goal, obviously. And like I said, I've had patients who've done all that testing and been put on something and they felt like it really helped. And so I also want to really listen when they say, no, like, that progesterone they put me on did help. But again, make sure the risks are understood and that we're really talking that through. So I really appreciate that.
Tara, thank you so much for a great presentation. And just so you all know, Tara is back after the holiday break at the first week in January to kind of continue this conversation a little bit. So we're excited to hear more. So Tara, thank you so much for a great presentation.